Hello viewers and listeners, I am Dr. Jeeva Vijayan. I am consultant cardiothoracic and aortic surgeon at Indraprastha Apollo Hospital, New Delhi. Today we are discussing about aortic valve diseases, and we have with us Dr. Niranjan Hiremath, who is a senior consultant in cardiothoracic and aortic surgery, who leads Apollo Aortic program at Indraprastha Apollo Hospital, New Delhi.
Hello Jeeva, and thank you for the introduction. Hello viewers.
So let us quickly move on to the first question.
Yeah.
Sir, could you tell us in brief about what is aortic valve and how does it function normally?
Aortic valve is known as the gatekeeper of the circulatory system in the body. It is the main valve that is present between the heart and the aorta. Aorta is the organ or the blood vessel, the main blood vessel that supplies blood to the rest of the body. Aortic valve regulates the blood flow from the heart. When the heart pumps, the blood is ejected out of the ventricle into the aorta, and aortic valve closes and prevents the blood from going back into the aorta. Hence, it is a very important valve that helps in the circulation of blood in the body.
So what are the diseases that commonly affect aortic valve?
Aortic valve diseases can either occur individually on the aortic valve or as a combination with other cardiac heart valves. Some of the diseases include narrowing of the aortic valve called aortic stenosis, or severe leakage of the aortic valve called aortic regurgitation. There can also be infection of the aortic valve called infective endocarditis, where some of the infective particles or bodies can attach to the aortic valve and cause leaking or narrowing of the aortic valve.
Okay, so my next question would be, what is bicuspid aortic valve and how is it different from a normal aortic valve?
Thanks, Jeeva. That's a great question. The normal human aortic valve consists of 3 leaflets. All the 3 leaflets open and close at the same time, and that helps prevent the blood from going into the heart again after ejection. But about 1 to 2% of the population in the world can be born with an abnormally configured aortic valve called the bicuspid aortic valve, where the person, instead of having 3 leaflets, the person has only 2 leaflets, and the way it opens and closes is more in an oval fashion rather than a round orifice fashion or the round opening of the normal aortic valve. Over a time, what happens is these aortic valves can deteriorate in function and form and can cause numerous aortic valve related diseases. They can also be associated with aortic pathologies like aortic aneurysms, and they can present as emergency or as future aneurysmal dilatations.
Okay, great, sir. So rheumatic heart disease is common in India. Does this condition affect aortic valve as well?
Yes, absolutely. So rheumatic heart disease, being the most common cardiac valvular disease, can occur along with mitral valve, aortic valve, and even tricuspid valve. But the most commonly affected valve is the mitral valve, then followed by the aortic valve. It can occur together or as an individual valvular problem, and appropriate treatment should be taken as the patient needs it.
Okay. So as you've already told, it can either cause narrowing of aortic valve or leakage of aortic valve. So what are the conditions that results in the leakage of the valve alone, and what are the conditions we have to look out for in patients presenting just with leakage of aortic valve?
See, the leakage of aortic valve, otherwise known as aortic valve regurgitation, can occur either due to leaflet problems, or it can occur due to the annulus of the aortic valve when it gets dilated or it becomes bigger. That is the opening of the aortic valve when it gets bigger. And also sometimes if the ascending aorta is also dilated, it can cause leakage of the aortic valve. A combination of all these can cause severe aortic regurgitation.
So basically connective tissue disorders, especially Marfan syndrome or Ehlers-Danlos syndrome, which can affect the aortic root or ascending aorta and dilate it, can present with regurgitation.
That's right. So connective tissue disorders can cause even dilatation of the aorta, and hence the aortic valve, since it is housed as one unit of the aorta and the aortic valve, can also dilate and cause regurgitation or severe leakage of the aortic valve. Another important mechanism of having aortic valve leakage is when aortic valve can get infected, called the infective endocarditis, where there could be vegetations or small depositions on the aortic valve leaflets, and they can cause severe aortic valve regurgitation as well.
All right. So, moving on to aortic stenosis, does age or old age is a factor for development of narrow aortic valve, and how frequently we come across this situation?
Aortic stenosis can occur at different age groups, but the pathology or the mechanism of aortic stenosis or narrowing of aortic valve may be different at different pathologies. In younger kids, it could be due to congenital anomalies that aortic stenosis can occur. In bicuspid aortic valve in young patients can present as aortic stenosis or narrowing of the aortic valve. And as normal aortic valve leaflet degenerates in some patients, which can become calcific and narrowed, they can present in the later fifth or sixth decade of life, or when a patient is above 40 or 50 years of life.
All right. So, moving on to the next area of interest, what are the symptoms that a patient with an aortic valve disease usually present with, and what should they watch out for?
Aortic valve stenosis or narrowing can present as severe breathing difficulty, chest pain, and dizziness or syncope or fainting episodes. Aortic regurgitation, on the other hand, leakage of the aortic valve can present with severe breathlessness, chest pain, and progressive worsening of breathing difficulties, difficulty in lying down flat, or sudden waking up in the middle of the night trying to catch his or her breath. Aortic stenosis and regurgitation have similar type of symptoms, but aortic stenosis is far more acute in presentation sometimes.
Okay, thank you, sir. So, if at all the patient present with symptoms, what would you suggest? When should they call for help, and what are the investigations that they should get to diagnose the disease?
See, the moment we start seeing any of these symptoms, when the patient is feeling breathless or has chest pain, it's important to immediately present to your doctor and to a hospital. The doctor will examine you physically, will auscultate you. They can sometimes hear murmurs in your chest, or they are called cardiac murmurs or heart murmurs, and these can happen due to the leakage or narrowing of the aortic valves. And once the doctor diagnoses that you may have or thinks that you may have an aortic valve problem, he may subject you to transthoracic echocardiography, which is basically ultrasound of the heart, which gives you all the structural details of the heart. It is a non-invasive method of doing tests. He will also get an ECG, some blood tests, and sometimes in some situations the patient can also be subjected to a CT angiogram to look at the detailed anatomy of the aortic valve and the aorta.
So, if the patients don't have a very severe disease or a starting of the valve disease, or does not require an urgent surgery or intervention, how should they be monitored, and what are the lifestyle modification or medication that they should be on, so that we can prevent further progression of the disease or detect the disease early when it gets severe?
I think that's a very important point that you pointed out, that not all patients, when they have aortic valve problems or when they have any kind of cardiac valve problems, need urgent intervention or surgery. Many of them can be managed with just medications, especially patients who have mild to moderate aortic regurgitation or mild to moderate aortic valve stenosis and who do not yet meet the indication for surgery, can be treated with medications to decrease the load on the heart and also to improve the symptoms that a patient has. But what is important is these patients need to follow up with the cardiologist or the cardiac surgeon periodically preferably every 3 to 6 months, and get an echocardiography to track the progress of the aortic valve disease.
And the lifestyle modification that they need.
They should avoid any kind of strenuous exercise where you need to hold your breath and strain very hard. Avoid lifting very heavy weights of any sort. Moderate exercise is fine, like walking or brisk walking, and light jogging is okay. But once the disease progresses to more severe stage, there should be physical activity restriction to just slow-paced walking and nothing too strenuous after that.
Other risk factors like hypertension, diabetes, and hyperlipidemia, all these things also can have an indirect effect on the aortic valve and aortic valve disease, and it is important to keep all these diseases under medications and control. And if at all the patients are requiring surgery, is there a when should we intervene for aortic valve disease?
Absolutely. So once we look at all the images, and there are certain parameters that we look at on CT scans and on transthoracic echocardiogram, and we correlate this with the signs and symptoms that each individual may or may not have. Depending on this, a decision is made whether the aortic valve needs to be changed or it needs to be intervened. That intervention could either be through an open heart surgery or through minimally invasive transcatheter aortic valve surgeries.
All right. So, if which patients are ideal candidates for open surgery and which are ideal for transcatheter or endovascular options?
That is an excellent question, Jeeva, and I think it's the most common doubt that most people have in their mind who suffer with aortic valve problems. First and foremost, the current aortic valves, especially the minimally invasive or transcatheter aortic valves that are available in the market, are for aortic valve stenosis. We do evaluate these patients thoroughly, and if the patient is above the age of 60, the patient is not a fit candidate for open heart surgery or is considered high risk for open heart surgery. And if the patient has had previous surgeries or has multiple risk factors, then it is quite reasonable to have a transcatheter aortic valve replacement. But if the patient is quite fit and he's low risk for open heart surgery, then a minimal access upper sternotomy aortic valve replacement is advisable. In open heart aortic valve surgery, we cut out the diseased aortic valve and we suture in, we put in a new valve basically to give a new competent aortic valve to the patient.
Okay, sir. In open heart surgery, does all the valve has to be, all cases of aortic valve diseases need to be treated with complete replacement, or are there any options for repair of the native aortic valve itself?
Currently, the standard of aortic valve repair in the world, and also at Indraprastha Apollo Hospital at Apollo Aortic Program, is that if a patient presents with aortic valve regurgitation, not all valves have to be replaced. We will assess the valve on echocardiography, and also on the surgical table during the surgery. We assess the valve. If we can repair the patient's own valve, and if we can give a good durable valve repair and correct the problem, then we prefer to keep the patient's own valve. This helps prevent future anticoagulation, and the patient's own valve is always the best choice compared to any kind of prosthetic valves that are available in the market. But if for some reason the valve looks unrepairable on table, then we would obviously replace it with the best possible type of valve that is needed for a certain patient.
So moving on to valve replacement, then what are the types of valve that are available for the patients, and which patient require a specific certain type of valve?
See, aortic currently commercially available valves are either mechanical valves, or which are made out of pyrolytic carbon and metal, or tissue valves, which are made out of cow's heart tissue. That's called biological valves. They both have their advantages and disadvantages. Mechanical valves are preferred for patients who are less than 55 years old or less than 50 years old, as their life expectancy is at least for another 20 to 30 years. Anybody more than 60, we can implant a bioprosthetic or a tissue valve. Advantages of a mechanical valve are they last longer. They could last even for 20 or 30 years, but they have to consume a blood thinning medication called Coumadin or warfarin, and they need to do a monthly blood test to make sure that the blood is adequately thin enough to maintain the competence of the valve. However, on the other side, if we put a bioprosthetic valve, they do not have to take a blood thinner, but there is a specific lifespan of these biological valves. Since they are unnatural and they are from animal source, they degenerate over a period of time. They become hardened or calcified, and the average expectancy of a tissue valve to last is about 10 to 15 years, after which they may need another surgery or another procedure to correct the aortic valve issues.
So what are the risks involved in an aortic valve surgery?
As such, aortic valve replacement or repair is a very low risk surgery compared to many other complicated cardiac operations. The risk is all usually less than 5%, and about 95 to 98% it is a great operation to correct the pathology. When you meet your doctor, the doctor will assess you individually or assess the patient individually, and the risk and benefit of the procedure will be discussed.
So after the surgery, what are the medications that patients have to be on, especially blood thinners, and how should we monitor the appropriate level of anticoagulation for these patients?
Again, blood thinners are for patients who have mechanical heart valves, and they need to maintain INR or international normalizing ratio of 2.5 to 3.5, and in some newer valves it could be 2 to 3. They need to do these tests every month, and it will be done at either a lab or a doctor's office.
What is the approximate recovery time that is required after an aortic valve surgery?
Aortic valve replacement as a procedure takes only a few hours, but then we expect an ICU stay of about 2 days, followed by about 4 to 5 days of hospital recovery or ward stay. The patient is at Indraprastha Apollo Aortic program. The patient undergoes a planned rehabilitation program where it is tailored to every individual patient's baseline physical strength and abilities. And the patient is up and walking right from day 2 and should be in a position to go home on day 5 or day 6.
And thereafter you follow up on weekly basis or monthly basis?
Usually we get our patients to come back to us to follow up within a week, and then we also repeat another echocardiogram after the surgery to make sure that the aortic valve, that is the new aortic valve, is functioning well. The approximate time that it takes for a complete healing to occur is about close to 2 to 3 months, and there are a few precautions that we suggest or advise a patient during that period.
So finally, what is the cost involved in aortic valve surgery in India?
Yeah, that's a very important question, especially in our country. Aortic valve repair as such, just an aortic valve repair without needing artificial implantation of an artificial heart valve would cost anywhere around 5 to 5.5 lakhs. But if we have to implant an artificial valve, the cost could go up to 6.5 to 7 lakhs. If additional procedures are required, like a coronary bypass grafting or aortic aneurysm repair along with the aortic valve, then the cost can go up to 8 to 10 lakhs.
Thank you, sir. That was a very informative discussion about aortic valve diseases. So now we are concluding our session on this topic, and we hope that we have covered the basic queries regarding aortic valve and aortic valve disease. If you have any further queries, you can mention in the comment section and we will try to address those. And for further informative videos, you can follow the social handles of Apollo Delhi.